It's a question of patient preferences about the different outcomes, good and bad. And that really has not been answered by a 6-month or a 1-year study. And what really troubles me about the idea of early aggressive treatment are the natural history data from population-based studies. And these are data from Olmsted County showing essentially that if you assign patients to different disease states over a long time, that's not years, I think that can't be right. It's not 60 years from diagnosis, but I suppose it could be. But what's most troubling is that for the most part, patients are well on very minimal therapy, or they have mild symptoms, or they're well after having had a surgery for the majority of time that they experience Crohn's disease. So the question is, if you did early aggressive treatment for everyone, wouldn't you be over-treating patients? And going back to the Markowitz data, you can look at this as glass half empty or glass full. Yes, you have this great outcome here, only 9% relapsed over 18 months, but you're exposing all these kids to 6-MP when actually 53% of them at least would have been fine without any sort of treatment at all, it looks like. So early aggressive therapy is probably right for half of patients. It's probably exactly the wrong thing for half of patients. Which is which? How do we know? So this led me down the line of thinking that what we really need is risk prognostication. We need to understand who are the patients who are most at risk, who need early aggressive therapy. And this brought me back to my roots in epidemiology. I still think epi is not this arcane science. I think it really has a lot of use for clinical medicine. It's useful for diagnosis, differentiating normal from abnormal. You can identify risk factors. Hopefully these are modifiable risk factors. It's important for describing the natural history. What outcomes are we going to see? What's the effect of treatment? What are the predictors of outcome? Certainly important for quality improvement, and also it will ultimately be important for causation studies. This is the typical kind of epi study. Again, Olmsted County data. My friend Ed Loftus out at Mayo Clinic has been looking at these data for many years. These are the same 200 patients looked at for a long time. And the interesting thing is mostly the incidence rates have been flat, but curiously you see in the last decade or two, again, a sharp rise in incidence rates of both ulcerative colitis and Crohn's disease. And we don't think this is merely ascertainment differences over this time, because their methodology hasn't changed over the years. So why that sharp uptick very recently? I think it is important to understand that the patients that we see at tertiary medical centers are quite different from the patients seen out in the community who never make it here. This is an interesting study from Regensburg, Germany, where they looked at a population-based group of patients and referral-based patients. When they compared these patients, they were not different with regard to disease location, to gender, smoking behavior, or family history, but they were quite different with regard to age of onset, whether they were treated with steroids or immune modulators, and the selection effect increased with the duration of disease. So this tells you that if you try to do risk prognostication in patients referred to medical centers like ours, you may be misled. And again, to drive home the point, when was the last time that you saw a patient who did not have a relapse of their ulcerative colitis at all over a 10-year period? In this study out of Norway, 1/3 of patients had no relapse over a 10-year period. I've never seen a patient like that at Mass General, but they do exist in the real world. So I come back to Yogi Berra, a wise man who said, it's tough to make predictions, especially about the future. So how do we go about this? There are some predictors in the literature. You find that patients who need steroids for their first flare are likely to have a worse outcome. The younger you are at diagnosis, it seems, the worse the outcome. Smoking, clearly correlated with a negative outcome in Crohn's disease at least. Presence of perianal fistulas. Disease extent, the more extensive the disease, the worse the outcome. It makes sense. Disease location. Patients with ileal disease get more surgeries. Severe endoscopic lesions, deep ulcerations. This has been shown to be a negative predictor in both Crohn's and in ulcerative colitis. And there's growing interest in the serologic markers, the ASCA, the OMP-C, the anti-I2, the anti-CBER1. The more of these things that you're positive to in Crohn's disease, the higher your risk for surgery, it would appear in multiple studies, and the more complicated your disease will be. How good are these predictors? Well, one attempt at a prediction model came out of France, looking at a variety of possible predictors. They found that in multivariate analysis, age less than 40, the presence of perianal lesions, and steroids for first flare were all independent predictors of disabling course of Crohn's disease over a 5-year period. And how good are these? Well, if you have 2 or more factors, you have something like an 80% positive predictive value compared to 1 or no factors. But still, this is far from perfect. And what we would really like is a risk prognostication model that has a likelihood ratio not of 1 or 2, but really is strongly predictive, takes the pretest probability from 50% likelihood to a post-test probability of 90% likelihood. That's a clinically useful prediction rule. But we don't have that as yet. But we do have a growing understanding of pathogenesis of IBD, and this will eventually lead to better prognostication. This has been the model for a long time. It's a disease of mucosal inflammation. There are environmental factors, probably the flora. There are genetic factors that we're beginning to understand very clearly. In a large meta-analysis of 3 large GWAS studies, genome-wide association studies, Barrett et al., working with my colleagues at Mass General, came up with more than 30 genes or genetic loci that are associated with susceptibility to Crohn's disease. And you can see that the odds ratios for these genetic loci go as low as 1.11. So they have very low explanatory value for the risk for the disease. But what is very interesting is that many of these genes or loci line up in physiologic pathways, the IL-23 pathway, IL-12, JAK2, all lining up in one pathway, and another pathway lining up with autophagy, which is a process we've barely understood as of just a few years ago. This gene, ATG16L1 and IRGM. So I'll talk for a moment about autophagy since many of us have barely heard about it. Autophagy means the cell eats itself, autophagy, Greek, I guess. And it is a process whereby degraded proteins can be recycled in the cell through proteasomes, or whereby invaders, viruses and the like, bacterial invaders, are enter into an autophagosome where these are broken down into an autolysosome. So it's a way, essentially it's innate immunity, a way of dealing with invaders into the cell. And you can imagine that if autophagy is defective, there's ineffective clearance and you get persistent infection, which may lead to granuloma formation. So a lot of things are suggesting that innate immunity is defective. But only 50% of Crohn's disease can be explained by genetics. We know this by twin studies. So what about the other 50%? Well, clearly there are also environmental risk factors. How else could you explain that sharp upswing in incidence in Olmsted County in recent years? It isn't that the genetics in Olmsted County have changed so dramatically. So the hypothesis here is that for early onset disease, for familial Crohn's disease, there's probably going to be a strong genetic basis and a minor environmental influence. And in more common cases of idiopathic Crohn's disease, probably there's subtle genetic dysfunction. Maybe you have 1 or 2 genes that are abnormal with a weak effect, but there's probably a profound environmental influence.